Hi everyone, can you hear me? Can people hear me? Just say, yeah, there we go. All right, perfect. So, hi, my name is Dr. Bashir, and I am a FY1, currently in the West Midlands, and I'm one of the final year leads at Mind the Bleep, and I'm presenting just a quick session on acute coronary syndrome with my colleague, Dr. Zenel Qenami, who is one of the medical leads at Mind the Bleep as well. Okay, so we'll get started at around 6:05. We'll just wait for a few more people to join, and we should be able to get started. By the way, on your screen, is it just the slides that you can see at the moment? Can you see the red slides, or is it just my face? I don't know which one.
We can see the slides on Canva.
Perfect. So they can see the slides on Canva. All right, great. So yeah, we can make a start in about 5 minutes. All right. Yeah, just again, just to everyone who's just now joining, as I said to everyone else, we'll just make a start in a couple of minutes. All right, we'll just wait for a few more people to join, and yeah, then we can go. Hi everyone. So as I promised, it's 6:05. So let's make a start. I don't want to delay you guys too much because it's a Saturday night. So let me just put this on full screen. Hopefully you guys can all see it. So as I said, we're going to be talking about acute coronary syndrome today, which will essentially is synonymous with a heart attack, right? But we're going to be talking about the three different forms from less severe to more severe that can progress from unstable angina all the way to an ST elevation myocardial infarction. And we'll explain further what these terms mean. So thank you for joining us. So what is an ACS? What is an acute coronary syndrome, right? So essentially, it's either a partial or a full occlusion of a coronary artery. So we have these coronary arteries that supply the heart muscle, right, with oxygen. And essentially, when any of these are blocked, essentially the muscle that it supplies and the area that it supplies of the heart can become necrosed or / dead, right? Obviously, that occurs over time. And during that time period, is really the golden time for us to intervene. And we'll talk about that later. And characteristically, this occlusion is not relieved by vasodilation. So in angina, usually what will happen is the coronary vessels vasodilate to compensate, right, for the obstruction, which is usually an atherosclerosis of some kind. However, in this case, even though there's maximal vasodilation of the coronary artery to try and compensate, the occlusion is still there. The occlusion is getting bigger and bigger and bigger, right? And we'll talk about why that could be because of the causes. And that is what is contributing to the pain. And the pain is just because of ischemia, because there's less oxygen in going towards that heart muscle, right? And essentially that will cause pain in that heart muscle. That will stimulate some of the pain fibers, right? Because of the lack of oxygen, right? And another characteristic feature is that the pain is not relieved by rest or GTN, whereas angina is relieved by rest or using GTN spray, which is a type of spray that is a vasodilator. Again, that's to increase the amount of oxygen supplied to the heart. Okay, so hopefully that makes sense. Now, again, how do we differentiate it from angina? Usually, this is associated with hemodynamic instability, usually meaning a low blood pressure or a high heart rate, right? And also associated with some nausea and vomiting, which we can also control, that we'll talk about later as well, and also some cold and clamminess as well. As I've talked about angina a few times, usually angina is what precedes this condition. Okay, so usually patients will have a history of angina, history of intermittent chest pain before their acute coronary episode. All right, and without treatment, it will result in eventual death of the myocardial tissue. As I said, if we don't treat within that golden time period, then there'll be death of the tissue. And the most common cause is usually a rupture of an atherosclerotic plaque. And atherosclerosis usually just builds up because of our diet, because of smoking and other lifestyle factors, and sometimes it can be genetic as well. And usually that when that builds up, eventually it can become weak and rupture. And that rupture then causes an occlusion of the blood vessels. All right. And as I said, there's three categories from less severe to more severe. And basically their category is based on the amount of arterial occlusion, and also that therefore is synonymous with the cardiac markers that we'll talk about, known as troponins. So you've got unstable angina, NSTEMI, and then STEMI, right? That's from least severe to most severe. Okay, and this image in the corner just basically shows that what it kind of looks like, the atherosclerotic plaque, and then when it ruptures, we have a complete blockade of that vessel. In terms of the mapping of the coronary arteries and exactly what areas we're looking at, the main things to really note here, right, is that you have three types of arteries. You have the epicardial arteries, and these are the main coronary arteries that we know of, such as the right coronary, the left coronary, etc. Then you have the intramural arteries, which are the arteries connecting the epicardial to the subendocardial, which is right on the interior of the heart, right, on the interior of the cardiac muscle, right, in the subendocardium, we call it, right? And then you have the subendocardial arteries, all right? So what happens is usually during systole, when the heart is contracting, these intramural arteries, they're pressed, and therefore there's no blood flow going through them, right? And usually in normal people, that's completely fine by us, because we don't really usually have a blockage in our heart. So there's usually normal oxygen flowing. So, having a little bit of a lower oxygen flow when the heart is contracting is fine. Obviously, for people with a blockage, though, this can be significant. And this is where pain can arise, right? And that's what usually can cause angina. It's usually when the heart is contracting and the intramural arteries are being pressed, then you have that excess of lack of blood flow, essentially. And that's really usually felt by the patients, and therefore they have pain. And as I said, so you have the epicardial arteries, and they're the ones that are most commonly affected in the MI, and we'll talk about that. And most commonly, the epicardial arteries that are affected, and the one that you usually be assessed on in exams, are the right coronary, the left anterior descending artery, and the left circumflex artery. And the left anterior descending and the left circumflex, they're both branches of the left coronary artery, right? So essentially you have the right coronary and the left coronary. Okay. Now, in terms of the areas that they affect, we can see that this kind of picture in the corner, right? Well, the two pictures actually, in the upper corner and the bottom corner. In the bottom corner, just looks at the ECG changes that they correspond with. And the upper corner looks at the vessels in terms of where they supply anatomically, right? So the main thing to note is that the right coronary artery, right, it can branch off to the posterior descending, and usually it will just affect the right side of the heart and also the posterior aspect of the heart most commonly. You have the left anterior descending, which usually affects the front aspect of the heart, right, the anterior heart, part of the heart, and also the septal part of the heart. And then you have the left circumflex, which is usually the lateral area of the heart, right? And if you can just imagine all the ECG leads, that will correspond to them. So as you can see, the anterior leads, right, which are lead 2, 3, and AVF, that's usually where we see the ECG changes if the left anterior descending is affected, because it's the front part of the heart that's affected, and also the septal part, right? That's why an anteroseptal, as well as we can see in that little box, is also signified when the left anterior descending artery is affected. And that's where we get changes in 2, 3, and AVF leads, right, on the ECG. Whereas if it's a lateral MI, then it's usually left circumflex artery that's affected, as we said, which is so, and usually the leads that correspond to that are V5, V6, lead 1, and AVL, right? And then one last one is if we just look at the posterior, I don't think it's on here actually, but for a posterior MI, usually it is the right coronary that is affected. And also for an inferior MI, it can be a right coronary as well, or circumflex, depending on which one's supplying the posterior aspect of the heart. But most commonly, it is usually the right coronary that's affected. Okay. Hopefully that makes sense. I know that was a bit of a brief overview, but when you guys can look back on this presentation, hopefully it'll make a bit more sense to you. So the classification. So the three types of MI that we have, as we said, unstable angina, NSTEMI, and STEMI. So an unstable angina is characterized by normal troponins, right? And you do have a acute coronary artery occlusion, again, usually due to a rupture of a atherosclerotic plaque, and the blood vessel starts to occlude bit by bit, right? But it's usually a partial occlusion. And here, what's happening is there's ischemia in the subendocardial region, meaning the most inner part region of the heart, because that's the furthest away from the blood vessel. Okay, so that's the area that's going to be first affected. Okay, because that's where the blood is already struggling to get to. All right. So when there's an occlusion there, blood is struggling to get there, oxygen is struggling to get there, and we have ischemia there. However, we don't have any necrosis yet. Right, we don't have any death of tissue, which is why the troponins are not raised. So there's normal cardiac markers here. However, there might be some associated ECG changes, and we'll talk about that. An NSTEMI, on the other hand, is also synonymous with a subendocardial infarction. So that area that's ischemic and unstable angina becomes necrotic and becomes dead. Okay, and here, because obviously there's some dead tissue, that releases troponins, which is basically just a protein that's found within the cardiac muscle. Okay, and then a STEMI is where there's death across all three layers of the heart in a particular area that a coronary artery supplies. Okay, and here obviously there are some elevated cardiac markers as well. And instead of the coronary artery occlusion just being partial, like it usually is in STEMI and unstable angina, here it is a complete occlusion right at the proximal aspect of the coronary artery. Okay, and that leads to all three layers being affected, and therefore we have an infarction or a death of all three layers, and therefore the troponins will be significantly raised here. Okay, and there's just a diagram at the bottom to just make sense of it. Right, and why we call it NSTEMI and STEMI, we'll talk about that a little bit later, but it's just to do with the ST elevation just on the or depression on the ECGs. Okay, in terms of investigations, so what do we look at on an ECG? So we've got usually the number one, what do we look at in a patient with an MI? So the first thing we look at is an ECG, right? We do a resting ECG on patients, and we look at kind of 4 or 5 different things. Number one, we see if there's ST elevation. Okay, if there is ST elevation that we can see on this diagram here, can you see that here? Just some ST elevation here, right? Which is basically the ST segment of the ECG becoming elevated, right? If that's the case, then that is a diagnosis within itself. Okay, we don't even need to look at the cardiac markers. All right. At that point, usually what we would do, if it's a new ST elevation, we would treat the patient for an acute coronary syndrome. All right. However, if there are other changes, such as ST depression, as we can see here, if there's any pathological Q waves, and we'll talk about what defines a pathological Q wave, and also if there's new left bundle branch block and any T wave changes, such as inversion or hyperacute T waves that we can also see on this diagram, then that can be indicative of unstable angina or a NSTEMI. However, it's not diagnostic of either. And in that case, we would need to do a test of cardiac markers. We need to do a troponin test. Okay. Now, in terms of what we consider pathological Q waves, there's 4 different things. Number 1, if it is 1 millimeter wide. Number 2, if it's 2 millimeters in depth. Number 3, if it's 25% of the depth of a QRS complex, right? Obviously, this is just estimates. They aren't like completely accurate. And then number 4, if they're seen in leads V1 to V3, which they're usually not supposed to be seen in. Okay. So that is usually the definition of it. And that is when we suspect an MI just from obviously electrophysiologically. But of course, we have the clinical context and we have more investigation to look at too. So as I said, with patients with unstable angina and a NSTEMI, an ECG is not diagnostic. It is only suggestive. So we need to do a troponin test, right? So what is a positive result on a troponin test? Usually, if there's elevation above the 99th percentile in a patient with signs and symptoms of ischemia, okay, that's when you only need to do one troponin test and you can diagnose the patient, and therefore you can go ahead and progress with ACS treatment. Okay. However, if it's below the 99th percentile, but it's still quite high, right? Or maybe the patient, they still have symptoms that are suggestive of an MI and you're a bit scared. So therefore you would just repeat it at 1 hour. And if that's negative, then you can repeat it at 3 hours, depending on the clinical context. It really just depends on trust guidelines as well at your various hospitals, all right? Because they will vary. But the main thing to note is if the troponin is raised, right, then as I said in the previous slide, that will indicate an NSTEMI. If we have an ECG that has some changes, right, and the troponins are not raised, right, then what we can assume is that the patient might have an unstable angina. And we treat an unstable angina very similar, if not identical, to an NSTEMI, okay? The couple other things that we do is we do echocardiography. So after an MI, after a part of the heart has either died or a part of the heart has been under a lot of stress, we need to check if the patient is at risk of heart failure, okay? So we always do an echocardiography in all patients after an acute coronary episode. And then last but not least, we do a GRACE score. And this is usually for patients with unstable angina and NSTEMI. And this is essentially to stratify patients whether they need to have either pharmacological intervention or instead go for surgical intervention. Okay? Hopefully that makes sense so far. Don't worry, we're going to get some questions in a little bit, and hopefully that will wrap everything together. Okay? And it'll all make sense in your mind. Now, in terms of the management, initially with all patients, and this is where, you can imagine yourself maybe in an OSCE scenario, in an A2E assessment, right? Or even when you're working on A&E, the first few things that we do, right? We firstly sit the patient upright, okay? That will help with their breathing, all right? Because a lot of patients, they're tachypneic, okay? It's not because they usually have a oxygen requirement or a new oxygen requirement, anything like that, but it's usually the case that patients are quite out of breath, right? With an MI, they're very stressed. So you sit the patient upright, help with their breathing. Sometimes you give them supplemental oxygen, but it's not a requirement. But then the 3 things that are a requirement is we would give morphine, right? Because they're in a lot of pain. We would give metoclopramide, so an antiemetic, and that's just because of the side effects of the morphine, number 1, but then also because a lot of patients with MI have nausea and vomiting, as we said before. And last but not least, we would give aspirin, and we would give a loading dose of aspirin at 300 milligrams, and that's according to the UK guidelines. Okay, and the reason why is because we need to have a early reperfusion strategy. We need to make sure that from early on, if we suspect something, right, that we give the patient some antiplatelets just to make sure that a clot is not forming. Okay, because that's what can happen when there is an atherosclerotic rupture. A clot can form within the vessels, and then that can completely occlude the vessels. All right. Now, in terms of the ongoing management, so we've managed the patient initially, right? But we're suspecting an MI now, okay? We've done the relevant investigations, and now it's time to actually consider whether we're going to do a surgical intervention or we're going to pursue or continue to pursue a pharmacological intervention. So for a NSTEMI, usually what we would do is if the patient is hemodynamically unstable, as I said, someone with a low blood pressure, someone with syncope, someone with a very, very high heart rate or potentially a new arrhythmia, right? Usually we would opt for a surgical intervention, okay? And that we would do immediate percutaneous coronary intervention. And what that means is essentially we go in into the coronary artery, so through the femoral artery, all the way to the coronary artery, and then we get a balloon, inflate the balloon, right? And then we put a stent in to keep that coronary artery open, okay? And essentially eliminate the occlusion, right? And we would do that immediately in patients who are hemodynamically unstable. Or if patients have an intermediate to high GRACE score, right, which is, as I said, the risk score to stratify patients, then we can do it within 72 hours, all right? Now, if patients are clinically stable and they have a low GRACE score, then what we would do, we would usually opt for pharmacological management. And the pharmacological management essentially just consists of ticagrelor and aspirin, right? So just dual antiplatelet therapy, okay? And if ticagrelor isn't a good option for the patient for some reason, then we go for clopidogrel, okay? Now, just to note as well, in terms of the anticoagulants that we use pre-PCI, right? It's the same for a STEMI and an NSTEMI, okay? So the process is exactly the same. If we go for a percutaneous coronary intervention, the anticoagulants that we give are usually the same. So we usually offer prasugrel, okay? Sorry, the antiplatelets we give, yes. So we usually offer prasugrel, okay, as an extra instead of ticagrelor for patients. Then we give an oral anticoagulant as well. So we usually give unfractionated heparin to patients. Okay, and then for all patients, we arrange for them cardiac rehabilitation and also some secondary prevention as well. Okay, meaning statins, blood pressure medications, etc., just to control all the risk factors. And we'll go into that a bit later. Okay, so as I said, so it's usually antiplatelet therapies, and for patients who are considered for a PCI, we give them an anticoagulant such as unfractionated heparin. Okay, and that is all here. These are all from the NICE guidelines. Okay. Oh, and just one last thing to mention as well. For all patients who we suspect have a ACS, right, the other anticoagulant that we do give for all patients as well, this is not just patients who are undergoing a PCI, is fondaparinux. Okay, so usually we give 2.5 milligrams subcutaneously as per the UK guidelines. Okay. Now, for a STEMI, a bit different, the guidelines. So usually it depends on timing here. So if the patient presents within 2 hours, right, within 2 hours of their being in hospital, right, and a PCI is available for them within 2 hours, and they're within 12 hours of symptom onset, then we can opt for a PCI, right? If it is more than 2 hours, so therefore they have to wait for a PCI for more than 2 hours, even though the symptoms are less than 12 hours, right? Then we would opt for fibrinolysis. So sometimes we can basically give a very strong, essentially, what we call it is we call it it basically lyses the clot, right? So just thrombolysis, essentially. Okay, and we would give an agent such as alteplase or something along those lines, and that is to completely destroy the clot. And that's a type of reperfusion therapy as well, but that's a pharmacological reperfusion. Okay, and that's the case if patients are more than 2 hours of presentation. In terms of then a PCI is not available to them within 2 hours. And then last but not least, if it's more than 2 hours of presentation / more than 12 hours of symptom onset, then usually we just go for pharmacological intervention. And it will be the exact same as for an NSTEMI, ticagrelor and aspirin. And that's according to the guidelines. Okay. Hopefully that makes sense for everyone. And as I said, for patients who we opt for a PCI for, the antiplatelet therapy is the same. So we give prasugrel to patients and we give unfractionated heparin. And usually it's the case. Sometimes I've seen that fondaparinux has been given, but actually according to the guidelines, usually we would go straight for the PCI, and therefore we would just go for unfractionated heparin for these patients. Okay, and again, for all these patients, we would opt for cardiac rehabilitation after, and also secondary prevention measures. This is just a quick slide just to mention people with diabetes, right? We have to adjunct their treatment, so whatever treatment that we opt for, right? Whatever ACS pathway that we go down, we need to give them a dose-adjusted insulin infusion, okay? And make sure that we maintain their blood glucose levels below 11 millimolars, okay? That's something important to know, and that's in the NICE guidelines as well, okay? In terms of secondary prevention, so really the main things are, we already talked about cardiac rehabilitation, but the pharmacological interventions that we have are usually we give an ACE inhibitor to patients so we control their blood pressure, because if we have a high blood pressure, we have a high afterload, and that can cause a cardiac remodeling, and that can essentially maybe lead down a path of heart failure for patients, especially patients with a damaged heart already. You don't want them to be pumping against a higher pressure, right? Because that will therefore, increase the risk of any heart failure occurring. Okay, so that's number one. Number two is the dual antiplatelet therapy. So we give aspirin and usually clopidogrel for 12 months. After we finish them 12 months, then we usually give aspirin or clopidogrel lifelong. Okay. We also give beta blockers to patients. So we usually give them, for example, either propranolol, if that's just one example, bisoprolol, etc. Okay. And we only continue it usually indefinitely if they've got a reduced left ventricular ejection fraction, meaning if they have evidence of heart failure, then we would continue it. Okay. And then last but not least, we would start them on a statin. So usually, because it's secondary prevention measures, we start them on a high dose of the statin. So 80 milligrams of atorvastatin is the most commonly used one. Just to note, for patients who are hemodynamically unstable during an MI, we would usually commence the ACE inhibitor and the beta blocker immediately. Okay, we wouldn't wait, because these are crucial times and the golden period to make sure no cardiac remodeling is occurring and therefore not resulting in any heart failure or trying to limit the amount of heart failure that occurs. Okay, hopefully that makes sense to everyone. The lifestyle changes and stuff, we don't really need to rote learn it, but it can be quite obvious. And just one last thing is patients who do have a reduced left ventricular ejection fraction, which means usually we're talking about equal to below 40%, right, ejection fraction. We would usually start them on an aldosterone antagonist, which is usually either spironolactone or epilepone. Okay. And last but not least, before we go into the questions, we just have the complications post-MI. And I've seen this being assessed in examinations multiple times. So I just want to just go through them quickly. So usually in the first hour of an MI, the main risks are going into ventricular fibrillation, essentially going into cardiac arrest, and also acute heart failure. Okay. After about, let's say, 3 to 4 days, right, the main risk is something called fibrous pericarditis, right? So for some reason, there are inflammatory processes that are going on in the heart because of the lack of blood flow that the heart experiences and the necrosis, and therefore it starts fibrosing. And essentially, this fibrosis can form a capsule around the heart and therefore limit the heart's contraction and therefore cause pericarditis, basically causing pericarditis. And it can eventually result in an acute episode of syncope, okay? After 3 to 14 days, we have our rupture syndromes. And what that means is, for example, the pupillary muscles might rupture, the septum might rupture, or the ventricles might rupture. And this can lead to stuff such as cardiogenic shock, ventricular septal defects, and also, for example, valve regurgitation. So, it can lead to a myriad of different complications. Okay. After 2 weeks, there is a risk of a thrombosis in the wall of the heart, and that can be caused because of the aneurysm in the ventricular wall. Also, we have something called Dressler syndrome. And what Dressler syndrome is a type of pericarditis secondary to an autoimmune reaction. Okay, and there's an autoimmune reaction that occurs in the heart essentially just because there's abnormal debris that forms around the heart because of the heart attack or the MI. And then what happens is the immune cells recognize it as foreign and therefore develop autoantibodies towards it. Again, they start attacking the heart, and that forms a syndrome called Dressler syndrome. It's a type of pericarditis as well. And last but not least, long-term heart failure as well, so chronic heart failure. So we've done a quick run through. Hopefully that's all made sense. Let's go into the MCQs. So we've got the first one. I'll give you a minute just after I read it out. So we've got a 62-year-old man is discharged following an NSTEMI after being treated with a PCI and stenting to the left anterior descending artery. He has past medical history of hypertension, type 2 diabetes mellitus, and CKD. The patient is symptomatic, but his echocardiogram shows a left ventricular ejection fraction of 45%. Which of the following is not routinely recommended for secondary prevention in this patient according to NICE guidelines? Please let us know in the chat. You can feel free to shout out if you'd like as well. But let's wait for everyone to put their answers in the chat first. Yeah, I'll give you 1 minute to answer this question. Okay, so we've got a bit of a split at the moment. We've got some going for D and some going for A, some going for B as well. Okay, let's wait for a couple more responses to come in. Give it about 15 more seconds. Okay, so we've got 66% of people saying D. So let's have a look. You're indeed right. It is D. So basically, the explanation is there, but I'll just read it out quickly. So usually, we only really use, as we said, aldosterone antagonists if the left ventricular ejection fraction is less than 40%, and therefore they have a diagnosis of heart failure, right? This patient has a left ventricular ejection fraction of between 40 and 50%. And also, just one other thing, and kind of a bit of a hint, is the patient has CKD as well. Patients with CKD are already at risk of hyperkalemia. So we don't want to give them an agent that will increase their risk of hyperkalemia more, right? And also, just in terms of the rest of the options, they're all valid. So dual antiplatelet therapy, as we said, we give. Statin therapy, we also give. And beta blockers, we also give, right? Especially in the short term. So that's just something to consider. And one last thing as well is cardiac rehabilitation we give for all patients, or all offered to all patients, okay? So well done, all of you who got that right. Next question. So we've got a 67-year-old man with chronic hypertension, peripheral arterial disease, and they present with intermittent chest pain. The ECG shows no dynamic ST changes, but the troponin I is mildly elevated. According to the NICE guidelines, what is the most appropriate next step in his management? Is it A, B, C, or D? Okay, I'll let you guys read that, and I'll give you a minute to answer. Okay, so we've got mostly, okay, so yeah, I think people are saying mostly one answer, but there's a couple going for A as well. Okay. Okay, we'll give people about 10 more seconds, and then we'll go through it. Okay. Yeah, we've got a lot of answers. Okay, great. So the answer is indeed B. So in this patient, we would calculate a Gray score to determine their risk because this patient has essentially a, well, we think it's an unstable, either unstable angina or NSTEMI, but the cardiac markers obviously would favor a NSTEMI, despite the fact that there's no huge ECG changes, right? And usually, therefore, using the Gray score would be really essential, so we know whether the patient needs to go for a PCI or we should go for pharmacological management. right? And just to note, right, with the GRACE score, because I didn't really talk about this properly, I just want to make sure people really understand this. So essentially, what it looks at is patients' risk of mortality within the next 6 months. If patients have a risk above a certain percentage, according to the GRACE score, then therefore we should manage them with a PCI, okay? Because they have a high risk of mortality within the next 6 months. All right. So hopefully that makes sense. And just one other thing to note is that thrombolysis is not indicated in this because obviously it's an NSTEMI, and that is reserved for a STEMI. So using alteplase or any other thrombolysis only for a STEMI. Okay. So MCQ number 3. We've got a 52-year-old man with type 2 diabetes mellitus, CKD, so another CKD patient, and a history of smoking with sudden onset central chest pain radiating to his left arm. The ECG shows ST elevation in leads V1 to V4. So we see ST elevation in the anteroseptal areas of the heart. Okay, which of the following best describes the most likely underlying pathophysiological mechanism of his condition? Is it A, endothelial dysfunction leading to coronary artery vasospasm? Is it B, progressive atherosclerotic plaque formation with chronic stenosis? Is it C, a plaque rupture with superimposed thrombus formation? Is it D, increased myocardial oxygen demand due to left ventricular hypertrophy? You guys let me know. By the way, I promise you the last question is a lot harder than this. So yeah, it's good that all of you are getting this right. I don't think we need to spend too long on this. We'll give it maybe 5 to 10 more seconds. Okay, great. So we've got most people answering C, which is correct, and some people answering B. So as I said, the most likely thing is you're right. There is an atherosclerotic plaque. However, this plaque usually ruptures and then a clot forms. For it to progress all the way into an occlusion without it rupturing is very, very rare. So most commonly, the pathophysiological mechanism would be C. Okay. And let's move on to the next one, because I think this is the most interesting one. And I want to give you guys 2 minutes to answer this because this is quite a tough one. So a 75-year-old woman with a history of hypertension and paroxysmal atrial fibrillation is admitted in with a inferior STEMI and undergoes PCI with a drug-eluting stent, which is just a type of stent, essentially. It's not a trick, it's not a trick there. To the right coronary artery. She has a CHA2DS2-VASc score of 5 and requires long-term anticoagulation. Which of the following best describes the most appropriate antithrombotic regimen following discharge according to the NICE guidelines? And now, please remember, it's a patient with concurrent AFib. Okay, so it's not just the heart attack that we're dealing with or the myocardial infarction, whatever you want to call it. We also have the AFib to consider. So you guys let me know. Take your time with this one, okay? Thank you. Okay, let's see what people are saying so far. Okay, we're getting a bit of a mix. Not that many responses on this one though. So let's wait until a few more people put their responses in. So okay, so we have most people. Okay, so most people are on the right lines, to be honest. A few people have opted for other ones, but I'll explain why it's not the case that we don't use the other regimens. We'll give you another 30 seconds to answer as well, okay? Because we have a few other people who still haven't responded yet. Okay. Good. Okay. Fine. So most people have responded now. So most people are in fact correct. So the answer is C. So for a patient with a concurrent AFib, usually patients with AFib, we would have a DOAC for them. Okay. And the reason why is because there's no, when blood collects in the heart, it's not like there's an endothelium, right? It's a clot that just forms there. So that's why we usually want to target the, primary and secondary the secondary hemostasis pathway, right? Not the primary. So it's not really the platelets that we're concerned about. It's more the clotting factors, etc. Right? That's why we're using an anticoagulant. However, for coronary arteries and, for example, in MI, there is obviously endothelium that the clot forms on, and therefore we're targeting more the platelets, right? So we need antiplatelets to cover that. So really, both are important. Okay. Now, the main thing that we would do here is we would use a DOAC, right? DOAC, aspirin, and clopidogrel for the first month, right? Then we would switch to just a DOAC and clopidogrel, and then just DOAC, right? And then basically just essentially resort back to what the patient was on before. Okay, so that is hopefully that all makes sense to everyone, right? Because obviously we still want to continue the DOAC for any stroke prevention in AFib. So yeah, hopefully that all makes sense to everyone. Does anyone have any questions at this point? I feel like maybe a few people are probably asking, why do we not use warfarin? Usually warfarin in AFib is only reserved for patients who have any valvular issues, all right? Such as a metallic valve, for example. Okay. But yeah, hopefully that all makes sense to everyone in terms of the pathophysiology and exactly what's going on. And that's it. I told you it'd be a very, very short session. It's only 40 minutes long. Thank you for listening. Please fill in the feedback form so we know what we can do for next month for our cardiology session, right? Hopefully you found it enjoyable, and also you found it very useful. And the recording will be uploaded onto Medall, okay? So if you didn't catch everything, then please make sure you go onto Medall in the next week or so and maybe take a look at it and just go over anything that maybe just didn't make too much sense or something that you just needed clarifying. Okay. Thank you all for listening. Yeah, and yeah, sorry, just to note as well, Zenel is doing a session. I'll be joining as well on the 10th of March, basically going through how to approach syncope. Okay, so that's really going to be useful, not just for written exams, but also for OSCEs as well. So remember to join that, pen it in your diaries. It's going to be really, really useful. I can guarantee you. Just to Paul, I'm more than happy to send you a copy of the slides as well. I will note down your email and I will send that to you. Okay. If any other people want the slides as well, just send across your emails via the chat and I'm more than happy to send them. Okay. All right. I think everyone has the feedback form now. Let's just make sure that everyone's filled. Let's have a look. Okay. Perfect. All right. Thank you all for joining. Really, really appreciate it. Again, please just remember to fill in the feedback forms before you leave the session, just because we can improve for next time and we can know what you guys want/need to be taught, okay, for your finals. All right. Thank you all for your time.